Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. In this video, we will explain the subciliary approach for periorbital region. Several incisions of the lower eyelid to gain access to the infraorbital rim and orbital floor have been described. The major difference between them is the level at which the incision is placed in the skin of the lower eyelid and the level at which the muscle is transected to expose the orbital septum or periosteum. Each incision has advantages and disadvantages. The most commonly used approach is the subciliary approach. It is also known as infraciliary or blepharoplasty incision. This incision is merely a lower lid incision at a higher level, that is in the lower lid just below the eyelashes. The main advantage of this incision is the imperceptible scar that it creates. Further, it can be extended laterally for exposure of the entire lateral orbital rim. In this picture, you can see the marking of the subciliary incision, and this is a closer view for the subciliary incision line just below the eyelashes, parallel to the this is the eyelid. Now this is another view. Here you can see the lateral extension of the subciliary incision. This lateral extension should be 1 to 1.5 centimeter. You can go up to 2 centimeter. We will discuss in the later part of this video. So as we said that skin incision is made just below the eyelashes. Subsequent to the skin incision, there are three optional pathways for dissection down to the orbital rim. That is subcutaneous deep to the orbicularis oculi muscle and step dissection or layered converse technique. Now, the first option is to dissect between the skin. This is, you can see, between the skin and the muscle. That is, there is only skin incision. Dissect between the skin and the muscle until the orbital rim is reached, at which point another incision is made through the muscle and periosteum to reach the bone. Now, the second option is to incise through the skin and muscle at the same level, that the level of the skin and muscle is the same, and dissect down just interior to the orbital septum and to reach the orbital rim. Now, the third option is this is basically the combination of option 1 and 2, in which the subcutaneous dissection towards the rim proceeds for a few millimeter, followed by an incision through the muscle at a lower level, that is at a lower level than the skin, producing a step incision, then follow the orbital septum to the rim. Now, although the three options are advocated by several surgeons, but each has advantages and disadvantages. Here you can also see the subciliary approach, that is a non-step, that incision passes through the skin and the muscle at the same level, and this subciliary approach, that is step, that is incision through the skin and muscle at two different level. So this subciliary step approach is recommended because it is associated with less complication as compared to the option 1 and option 2. Now, the first option, in which a subcutaneous dissection to the level of the infraorbital rim is made, leaves an extremely thin skin flap. This flap is technically difficult to elevate, and accidental buttonhole dehiscence can occur. A further problem that may occasionally be seen is a slight darkening of the skin in this area after healing. Presumably, the skin becomes avascular and essentially acts as a skin graft. Subcutaneous discussion produces an extremely thin skin flap predisposed to scar contracture and hence a high incidence of ectropion. Second option, in which the dissection is made between the muscle and orbital septum, is technically less difficult. Care must be taken, however, because the thin orbital septum can be easily violated, causing the periorbital fat to herniate into the wound. In practice, this is more nonsense than a problem. The skin and muscle flap, however, presumably maintains a better blood supply to the skin, and pigmentation of the lower lid has not been seen as we discussed in option 1. Is the path of discussion is deep to the orbicularis oculi muscle that includes the pretarsal. This is a pretarsal muscle fiber in the elevated skin flap. The preseptal fibers of the orbicularis oculi muscles are not preserved here because you will detach it. So the position of the eyelid, this position of the eyelid and its contact with the globe is not maintained post-operatively, and the motor denervation can critically reduce lower lid tone and diminish vertical lid support that can lead to complications. So the complications associated with option 1 and 2 are skin button holes, scarring at the lower eyelid margin, darkening of the skin, ectropion, and occasionally entropion. Therefore, option 1 and 2 are not recommended. Uh, the third technique, in which the layered dissection is used, avoids the disadvantages of others. As we discussed, the main advantage of the step incision through skin and muscle is that pretarsal fibers of orbicularis oculi can be kept attached to the tarsal plate. Here you can see these are intact because incision is interior to the muscle, and the muscle pretarsal fibers of the orbicularis oculi can be kept attached to the tarsal plate, presumably assisting in maintaining the position of the eyelid and its contact with the globe. So in option 1 and 2, care should be taken to preserve the integrity of the orbital septum here. Orbital septum, otherwise there is the risk of a vertical lid shortening. The incision through the periosteum is through the periosteum for entry into the orbital to the orbit is made beneath the orbital rim. That is orbital beneath the orbital. This incision should be beneath the orbital rim. Step dissection outline here is technically easier than the other two options, that is option 1 and 2. It preserves pre-tarsal fibers of the orbicularis oculi, thereby limiting scarring at the eyelid margin as associated with step 1, option 1 and 2. So common complication associated with option 1 and 2, such as skin buttonholes, darkening of the skin, ectropion, and occasionally entropion, are minimized. And earlier we highlighted the advantages of step dissection technique are imperceptible scar and the ease of extending laterally for additional exposure of the entire orbital rim. Now we will explain the steps of subsidiary approach. and we will discuss the step, that is the option 3. Protection of the globe is the first step. A temporary tarsorrhaphy is recommended to help protect the cornea. This is done by employing a mattress suture. Here you can see the suture is left long to be used as a traction suture for the dissection. The skin crease around the orbit are carefully evaluated. If a lateral extension of the subciliary incision line is anticipated, it is useful to mark the lateral tail of the skin crease that pass inferiorly. The lateral extension of subciliary incision always follows the natural crease. If edema obscure the direction of skin creases, one may look at the contralateral eyelid to determine the direction and position of the creases. Marking of incision line is planned just below the eyelashes, paralleling the lid margin. The lateral extension runs out into a natural skin crease. It can reach approximately 2 centimeters past the lateral canthus. Next, the lower eyelid may be infiltrated using a local anesthetic containing a vasoconstrictor. The initial incision is carried through the skin layer only. The underlying orbicularis muscle should become visible when the skin incision is completed. A cotton tipped applicator, here you can see, may be used to elevate the lower eyelashes out of the surgical field while making the incision. A skin flap over the pre-tarsal portion of the orbicularis muscle is developed along the entire extent of the incision. Now here you can see the subciliary incision is being made. The incision is approximately 2 mm below the eyelashes and can be extended laterally as necessary. That is a top dashed line. It is made through skin only if one chooses to use a natural skin crease located more inferiorly. For incision, lower dashed line, here you can see the incision must follow the crease as it tails off inferiorly. One should not use the lower incision and then extend the incision more superiorly, not in this direction, as the lateral orbital rim is approached or the relaxed skin tension lines will cross. It will lead to a poor aesthetic result or a scar formation. Now, the skin flap goes inferiorly over an approximate distance of 4 to 6 mm. This is performed by sharp dissection with a scalpel or a scissor. Here you can see, and this clinical example shows the separation of the pre-tarsal skin flap. This is only a skin flap without the muscle. Here you can see the muscle. The intact muscular portion of orbicularis oculi muscle is revealed. Now, this approach is here you can see the what you have done so far. You have only taken the skin incision. Here you can see first this skin has been reflected. You can see the orbicularis oculi muscle, and this is a tarsal plate, and this one is the orbital septum. Now, next step is that you will incise the orbicularis oculi muscle in a step fashion. In a step fashion means that is at the level below this tarsal plate, below the in this area. But you will not cut it directly, otherwise you will damage this orbital septum. So first of all, the first step is that you will separate this orbital septum from this orbicularis oculi muscle, and then you will cut. Now we will see here how we will do it. The approach is continue in step fashion. The orbicularis oculi layer is undermined, and how it is undermined, that undermining will begins with a slit like lateral incision of the muscle over the bony infraorbital rim, that is at the lateral side. So use of scissors to dissect through orbicularis oculi muscle over the lateral orbital rim to identify the periosteum. Now, once you have identified the periosteum, now what will you do? That the suborbicular dissection plane. Now, this is a suborbicular dissection plane is opened by spreading scissor. Now, you can see here that the scissor has been introduced. This leaves the orbital septum intact. Now you are between the muscle and the septum. Here you can see. Now, this is a muscle. This muscles were attached with the this orbital septum. Now, spreading scissor are between the orbicularis muscle and the orbital septum. So these spreading these spreading scissors, these will separate this orbicularis muscle from the orbital septum, and when it is separated completely, then we will incise this muscle, that is the orbicularis muscle, in a stepwise fashion at a lower level than this initial skin incision. So the suborbicular pocket is extended downward, that is in the downwards over the interior ridge of the infraorbital rim. Now dissection between orbicularis oculi muscle and orbital septum. The dissection should extend completely along the orbital rim and superiorly to the level of the subcutaneous dissection, where we have dissected the or incised the skin. The pocket is extended over the whole of this palpebral region. Finally, the upper portion of the pocket below the tarsus is opened with a spreading scissors. This allows for a step incision of the muscle. Now we will see here the step incision of the muscle. This is a step incision of the muscle. Now incision of the muscle is done at a lower level than the initial incision of the skin at a higher level. You can see here. So this was initially the skin incision, and now this muscle has been separated from the orbital septum, and this is the bridge of the orbicularis muscle, and you will cut it in a stepwise fashion. So this incision of the muscle will be at a lower level with the initial incision in the skin. Now this will be a skin and muscle flap, because this was the only skin flap. Now when you will cut it, this hole will be become a skin and muscle flap, and it can be retracted very easily. So the remaining orbicularis oculi muscle is then separated at the level just below the lower border of the tarsus. Here you can see this is the just below the lower border of the tarsus to complete the step incision. This enables the retraction of the lower lid as a skin muscle flap incision through bridge, as we explained of the that the incision through the bridge of the orbicularis muscle. Now next is the skin muscle flap is retracted inferiorly. Here you can see inferiorly over the interior edge of the infraorbital rim along its whole horizontal extent. An incision through the periosteum at this level should avoid the orbital septum and is inclined to the lateral side. In this figure, incision through the periosteum along the interior maxilla, 3 to 4 mm inferior to the infraorbital rim, Note the pre-tarsal muscle fiber. Here you can see still remaining on the inferior tarsus and the orbital septum, which restrict the orbital fat from entering the field. Periosteal elevators are then used to strip the periosteum from the underlying osseous skeleton. The infraorbital nerve is located below the medial portion of the infraorbital rim and can be approached after the periosteal incision is made. After identifying the infraorbital foramen and the nerve exit zone, the upper facial surface of the interior maxilla can be dissected in the subperiosteal plane. The infraorbital rim is exposed superiorly for the subsequent periorbital dissection. Subperiosteal dissection of interior maxilla and orbital floor. Note in this diagram, you can note the periosteal elevator entering the orbit is placed almost vertically as the dissection proceeds behind the rim. In the interior region, the floor of the orbit, this is the floor of the orbit, is at lower level than the crest of the rim, necessitating dissection inferiorly just behind the crest of the rim. In this picture, an atomic dissection showing incision through the contents of the inferior orbital fissure to facilitate orbital dissection. These tissues should be cauterized with bipolar electrocoagulation to prevent bleeding when incised. An atomic dissection showing here increased exposure of the orbit after incision of the contents of the inferior orbital fissure shown in this picture. Now, how it is closed? The closure can be performed in 2 or 3 layers. Periosteum muscle, that is optional, and skin. The periosteum is draped over the bony surface and closed with resorbable interrupted suture. Suturing of orbicularis oculi muscle is optional in a limited approach. It is recommended if the approach is extended with the vertical cuts through the muscle and are excessive stripping over the zygomatic body. Resorbable interrupted sutures are placed laterally, in particular when the orbicularis oculi muscle has been cut at this position. The skin wound is closed with 60 non-absorbable or fast resorbing suture. Either running or interrupted sutures can be used. As far as the lateral extension of subciliary approach is concerned, the standard subciliary approach can be extended laterally to provide access to the entire lateral orbital rim to the level almost 10 to 12 millimeter superior to the frontozygomatic suture. This access may be used as an alternative to the lateral brow or the upper blepharoplasty approaches. The incision is extended laterally between 1 to 1.5 centimeter in a natural crease. In a natural crease or crow's foot in the elderly patient. If there is no natural skin crease, the extension can be made straight laterally or slightly infero-laterally. After extending the incision laterally, the orbicularis muscle is undermined over the lateral orbital rim in a superior direction. The dissection proceeds in the superior-periosteal plane and can be extended well above the zygomatico-frontal suture. Here you can see technique used to obtain increased exposure of the lateral orbital rim. The initial incision is extended laterally, as we said, 1 to 1.5 centimeter, and a periosteal dissection along the lateral orbital rim proceed towards the frontozygomatic suture. The soft tissues over the lateral orbital rim has been retracted superiorly with a small retractor to expose the periosteum. A vertical incision through the periosteal layer over the lateral orbital rim is made approximately 3 to 4 mm lateral to the inner bone edge. First, the subperiosteal dissection will proceed along the entire lateral orbital rim all the way up to the frontozygomatic suture. Second, the dissection frees the periosteum over the lateral orbital wall into the orbital cavity. This lateral canthal, here you can see the lateral canthal tendon will be stripped from its insertion with the dissection of the periosteum. Here you can see the lateral canthal tendon has been stripped and retracted. Now, the dissection to the level, in this, you can see the dissection to the level of frontozygomatic suture, the tissue superficial to the periosteum are retracted superiorly with a small retractor and an incision through the periosteum, as we said earlier, is made 3 to 4 mm lateral to the lateral orbital rim. Subperiosteal dissection exposes the entire lateral orbital rim, and a dissection into the orbital rim frees the tissues. Now the tissues are free and allows a retraction superiorly. The periosteal incision over the lateral orbital area and the infraorbital rim, then these are connected. The periorbital dissection that frees the tissue from the lateral orbital wall and the orbital floor to the sphenozygomatic uh, suture line and to the infraorbital fissure. Thus, the inferolateral circumference of the orbital cavity can be exposed from the frontozygomatic suture to the zygomatico-maxillary suture and posteriorly to the sphenozygomatic suture and infraorbital fissure. Whole of this area has been exposed by the lateral extension of the subciliary approach. No lateral canthopexy is necessary if careful repositioning and suturing of periosteum along the lateral orbital rim are performed. This maneuver brings the superficial portion of the lateral canthal tendon into proper position, giving the lateral canthal, lateral palpebral fissure a satisfactory appearance. Suspensory suture or frost sutures. One problem that may accompany any incision to gain access to infraorbital rim and orbital floor is a vertical shortening of the lower lid after healing. This probably occurs as a result of scarring and shortening of the orbital rim of the orbital septum. Sorry. To reduce the incidence of this problem, superior support of the lower lid for several days or until gross edema has resolved after surgery is beneficial. So subsidiary approach may be complicated by vertical scar contraction during the healing period with an ectropion. Skin and septal scarring may be counteracted by the so-called frost suture. This suture is a matrix suture through the gray line of the lower lid and is applied at the end of the operation. It lengthens the lower lid when it is taped to the forehead. This creates traction for several days until wound healing has passed its first critical phase. The taping to the forehead is done in several layers in order to suspend the suture firmly and prevent downward slippage. The suture is positioned over the suture positioned over the first layer of the tape, which is applied directly to the skin. It is then secured with a second tape over it. Next, the suture is folded over this second layer and another strip of tabs secure it finally. This lower lid suspensory uh, suture placed at completion of the surgery. The suture is placed uh, just below the lower eyelashes, but just above the subciliary incision, taking care to engage the tarsal plate. This incision must pass through the tarsal plate. It is uh, below, that is below the eyelashes, but above the subciliary incision and passing through the tarsal plate. It is taped to the forehead in a manner shown to provide firm suspension. If you will not suspend it with three layers of the tab, then it will lead to slippage. So it is taped to the forehead in the manner shown to provide firm suspension. Post-operative examination of vision is possible by either removing the two uppermost layers of the tape and opening both eyes, or by reflecting the upper eyelid only. Thank you. Wish you best of luck.